Good morning, everyone. My case is about a bilateral macular coloboma. And coloboma is a congenital retinochoroidal defect in a macular region, and it is thought to result from incomplete differentiation of the arcuate bundles along the horizontal raphe during developmental, or they may result from some intrauterine infection. It referred to a circumscribed excavated defect in the choroid and retina at the macular area associated with decreased vision. It is associated with some skeletal abnormalities which have been reported frequently and attributed to be either embryological maldevelopment or inflammatory etiology. Coming to the case report, a 60-year-old female patient came to OPD with complaints of diminution of vision since childhood, which aggravated since 2 months. The visual acuity, best corrected visual acuity was 660 and N36 in the right eye and 636 and N36 in left eye. The IOP was 14 and 18 mm of HG in both the eyes. Macular function test showed Amsler grid showed central scotoma in both the eyes. Coming to the fundus examination, both the eyes showed the same finding, like it showed a gross annular crescent, and macula showed a well demarcated atrophic lesion of 3/4 disc diameter on the fovea, with shiny surface and choroidal vessels were seen through the lesion. There were no drusens or any RPE abnormalities around the lesion. The retinal vessels were normal and there were no pigmentary changes in the retinal periphery. Coming to the OCT of right eye, it showed a foveal thinning of 105 microns, and RPE and retinal atrophy over the central macula was 1600 microns. Choroidal hyperreflectivity seen over this area, and ellipsoid zone and external limiting membrane are missing in this central area. The internal inner retinal structure looks normal outside the fovea. The left eye also saw the shape, and only the foveal thinning showed 140 microns, and RPE and retinal atrophy showed 1000 microns. Other findings were same. Coming to the discussion, Idaman classified the maculocolobomata into 3 types based on the ophthalmoscopic appearance. One is pigmented and non-pigmented, and another type. Pigmented, where the circular patch at the macula covered by the irregular mass of pigment beneath with the choriocapillaries will be seen. That indicates the main lesion is deep to the inner retinal layer. And the non-pigmented type, the pigment will be clumped and everything will end up with the edge. And the third rare type will have the neovascularization over the coloboma. In our case, the patient had poor vision since childhood in the both eyes. Both eyes showed well circumscribed central areas of outer retinal atrophy, including RPE and choriocapillaries. There was no pigmentation or choroidal atrophy or scleral ectasia in the lesion in both eyes. To conclude, absence of vascular narrowing or pigmentary spicules in periphery rules out the retinitis pigmentosa or any other retinal dystrophies of other cause of coloboma, and there were no systemic features in our case. And however, it is concluded as an isolated bilateral macular coloboma, which is incomplete. Thank you.
Thank you, doctor.
Did you do an ERG for this patient?
No, sir. ERG, actually, patient was not willing to proceed with any investigations. OCT also we compelled and did, and ERG we didn't proceed with all.
No, because the diagnosis of macular coloboma is a little suspect in this case, I would think. Why not heredomacular degeneration?
Yes, sir.
Arterial attenuation is not seen in all patients with HMDs.
Okay.
Autofluorescence was done?
No, sir. Only OCT was done. Thank you, sir.